Hi, this is Janice Lopez from the International Organization for Migration, and welcome to the Migration Health Research Podcast. In this issue of the Migration Health Research Bulletin number 25, we feature articles, reports, and guidance documents focusing on vaccination coverage, infectious diseases, mental health, health emergency, and health information management systems. In this audio podcast episode, we feature two interviews, one with Dr. Farah Amin and the other with Dr. Radheshyam Krishna KC. Dr. Farah Amin is the Migration Health Division's Regional Vaccination Program Coordinator for Sub-Saharan Africa, who is based in IOM Regional Office in Nairobi. He outlines the result of the study, which looks at the immunization coverage of refugees being resettled in the United Kingdom who underwent IOM's health assessment program. Let's listen to Dr. Farah Amin.
The primary goal of this retrospective population-based cross-sectional study was aimed at assessing the immunization coverage of UK-bound refugees undergoing International Organization for Migration Health Assessment through UK Resettlement Scheme and also calculate risk factors for under-immunization. This is a retrospective population-based cross-sectional study of all refugees in the UK resettlement program who had at least one migration health assessment conducted by IOM between January 1, 2018 and October 31, 2019 across 18 countries. The age of the refugees was categorized as per WHO definition, and this included children below 10 years, adolescents aged 10 to 19 years, and adults 19 years and above. Individuals' recorded vaccine coverages were calculated for each disease by combining historical doses with those given in the final migration health assessment, and this was compared with the UK immunization schedule and the UK refugee technical instruction. Further, a multivariate logistic regression analysis was also applied to assess the factors associated with varying immunization coverages.
Dr. Farah, can you share with us some of the key findings from this study?
This study included 12,526 refugees. Among them, 50.9% were male and 49.1% female, 31.3% children less than 10 years, 21.8% adolescents between the age of 10 to 19, and 46.9% adults who are 19 years and above. Out of the 36 nationalities, Syrian nationals were noted to be the majority with 63.5%, which translates to 7,955 individuals. 98.2% of the refugees in the study were in a country different from their nationality when undergoing their migration health assessment. Furthermore, a total of 26,118 doses of vaccines were administered by IOM, and MMR, which is measles, mumps, and rubella vaccine, was noted to be the highest with 33.5%. Out of the refugees included in this study, 6,780 departed for UK. Their vaccine records checked and compared with the UK technical instruction with key findings as follows. 80.9%, which translates to 5,556, had at least one measles-containing vaccine. 84.4%, which translates to 5,798 individuals, had at least one dose of polio vaccine, and 19.1%, which translates to 1,350 individuals, had at least one dose of diphtheria and tetanus-containing vaccine. Similarly, comparison was also done with UK immunization schedule with the following key findings. 11.1%, which translates to 764 individuals, were noted to be fully aligned for polio. 34%, which translates to 2,334 individuals, were noted to be fully aligned for measles, and 5.5%, which translates to 380 individuals, were noted to be fully aligned for diphtheria and tetanus. It is also noted that vaccination coverage of refugees departing for UK are suboptimal and varies by age, where adults and adolescents are noted to be significantly less likely than children to be in line with the UK immunization schedule for polio and measles. Nationality where Sudanese and Eritreans most frequently had low reported coverages for key vaccines, while Iraqis nationals recorded high coverages. Country of health assessment, where in Turkey, individuals most frequently had at least one dose of vaccines, while in Egypt, the individuals were least likely to have the same. On disease, tetanus and diphtheria were noted to have the least coverages.
As my last question, Dr. Farah, what are the implications of all this evidence to policy and practice?
In UK and other refugee-receiving countries, this study will guide and strengthen delivery of refugee pre-entry health assessment and develop domestic initiatives including catch-up policy targeting migrants of all age groups, more so the adults and adolescents, who are often excluded from vaccination services on arrival with no system in place to offer catch-up vaccination services. This will positively contribute towards achieving a key objective of the new WHO Immunization Agenda 2030 framework for action that aims at improving vaccination coverages for refugees and other migrant groups. This study highlights the need for improved data collection and data sharing between IOM, other non-governmental organizations delivering immunization services in humanitarian context, and refugee-receiving countries. This study also highlights the need for clearer definitions on where the responsibilities for providing vaccines to resettled refugees lie between host countries and health assessment providers.
We also spoke to Dr. Radheshyam Krishna KC, Migration Health Project Officer, who was formerly from IOM Nepal and is now in IOM Libya based in Tunis. He discusses the findings on the management of migrant health information in Nepal. Let's listen to Dr. Radheshyam Krishna KC.
The objective of the scoping review was to explore the landscape of migrants' health-related information in Nepal. And to do this, we tried to identify and analyze health-related information available, explored available management information system, and stakeholders mapping and various challenges to keeping a record of such information. For this, we used the scoping review, this 6-step methodological framework developed by Axel and O'Malley. We followed all 6 steps. In the first step, I identified the research questions. We framed 4 specific questions for this study. And those were, one was to, what is the status of health-related information of migrants of Nepal? How are migrants' health records maintained and analyzed? Who keeps migration health records? And what are the challenges for mainstreaming or maintaining migrants' health record in Nepal? So at the second step, we use various type of keywords, especially the 3 types. The migrant population, mainly the student migrant, labor migrant, immigrant, international migrants. Then indicators for health information like death, injuries, mental health, this kind of health indicators. And the geographical area as Nepal. So these 3 categories of keywords were used to search in Google, PubMed, and any other research dashboard for the scientific and grade literature to identify the studies conducted to assess health-related information about migrants in Nepal. Literature was also identified through snowballing searching and during the expert review process to identify more sources. And the various other websites were also searched, especially for the reports. And at the third step, all the information we tabulated and extracted the data. We analyzed the data. In the fourth step, we collected the information from all literature review as well. At the fourth step, we had to do the stakeholder mapping because unlike other review where we just focus on the literature or the grade literature and reports, but here we also need to do the stakeholder consultation. So for this, we did the mapping of stakeholders. We relevant all the reports or the information management system that they had. And finally, in the sixth step, we did the stakeholder consultation through a key informant interview and focus group discussion. So at the time when we conducted this study, the COVID had just started. So country was in the COVID-19 restriction. So most of the interview we conducted through phone interview. And for the focus group discussion, we used the Zoom platform. So we invited 9 participants from Pre-Departure Health Assessment Center to participate and contribute in the discussion. So all the information we also analyzed. We received for the whole process, and we got the ethical approval from Nepal Health Research Council.
As my next question, Dr. Casey, what are the findings that you want to share with our listeners about the study?
So actually for the findings, because most of the literatures are already available, so we know majority of the health issues of the migrants, either it is they are in Europe or in US or in GCC countries, but the migrants from Nepal or South Asian countries, they have very low education level. That's why they have limited access to health services. There are many barriers that affect in accessing the services, and the provision of insurance coverage is also low. So death, disability, or any kind of workplace accidents are the common one, which are mentioned in various literatures. And especially the tourists who are coming to Nepal, the infectious diseases, especially the gastrointestinal diseases, are very common. So this sort of information were recorded. So because these information are easily available and in various literatures, but the information, like when we did the stakeholder mapping and collected few information, that can be interesting to everyone. So altogether we mapped 16 stakeholders. And out of these 16 stakeholders, we label them as level 1, level 2, and level 3 stakeholder. First level of stakeholders were directly involved in keeping migration health records. They were especially the Foreign Employment Board, the departure medical centers who do the pre-departure medical screening as per the integral part of visa processing. Also, IOM do the medical screening of refugee as well as the immigrant population. And some of the INGOs working on TB, HIV, and malaria, they also have the information management system where they keep record of every migrants with diseases. So at the second level, these are not directly involved in providing or accessing health information, but they are interlinked with other organizations such as Department of Foreign Employment. They have the Foreign Employment Management Information System in place. They are linked with the Foreign Employment Board because they are the governing body for labor migration. There are Department of Immigration. They have their system where they keep a record of all entry and all people who exit and enter the country, especially through the international airport and some of the ground crossing points. Then we have the Department of Health Service. They have the Health Information Center. So this is the center which monitor all health-related events. They also do the health programming based on the evidences for the Department of Health Service. Some of the insurance companies, especially the health insurance company, they have the record of different health issues and the compensation that people often claim. Third level, they are not involved in monitoring migrants' health, but they are more concerned with data management. These are the National Human Rights Commission, National Planning Commission, Department of Passport. And following COVID-19, we have the COVID-19 Crisis Center. So in a nutshell, the migrant health informations are highly fragmented. The information are there, but not systematically recorded. The pre-departure health assessment center, they do the health checkup, but it is linked with Foreign Employment Management Information System, but it is not systematically stored, so that retrieval of any information is a challenge. Foreign Employment Board, they have the record of migrant applying for compensation, but these are not very scientific. The description and categorization of causes of deaths are not scientific. Even the health management information system, they do not have the migrant-specific indicators. That's why it is not able to capture any migrants' health profiles. The Minister of Education, who gives the no objection certificate for the students applying abroad, but they have not mandated health certificate as an approval process. So there is no record of the health records of student migrants. The travel medicine clinics, they offer the services, but they are not linked to the health management information system. That's why findings were very useful in terms of identifying like who is doing what, how they are storing the information, and how they link to the existing government system so that the government can plan some program to uplift the health situation of various kinds of migrants. So we also explored what are the issues and challenges they face on keeping the record or maintaining this information management systems. Many stakeholders, they mentioned that the lack of technology and human resources, because most of the softwares used are not user-friendly, so these are not interoperable within other existing information management systems. That's why, so that was one of the challenges. The scope of health issue was also not quite easy to understand because pre-departure assessment center, they do the health screening at the pre-departure level. There is no system for post-arrival. Only those people who go due to various reasons either to Foreign Employment Board or to the hospital for checkup, those information on personal basis but not reported to the systems. The scope of health issues to be recorded is a challenge. There is no interest among the stakeholders to involve in the data management because health is the least priority, and for many stakeholders it is the remittance. They pay more attention. But everybody and all the stakeholders, they suggested and recommended for the unified system to keep a record. And this is how the Migration and Management Information System and its idea was come into place. And they also recommended for some cost-effective mechanisms and user-friendly systems so that all stakeholders can enter the data, keep a record of it, and information management be easy even for the government.
Very interesting findings. As you have mentioned, migrant health information system is very much fragmented at the time of the study. Those are very relevant information that you found out from the study. Moving forward, and I think you touched a little about this already, can you outline for us some key recommendations from the study specifically focused on the management of migrant health information in Nepal?
This scoping review itself is a method, and we comprehensively map evidences across a range of study design and in particular area of concern, especially for us, it was the migration health information management. In our context, we were able to collect information from various sources, published and unpublished articles. We also did the stakeholder mapping, also did the consultation. So based on that, we noted a need of a unified system for monitoring migrants' health and ensure the provision of essential health services. This is just the beginning. So there are some recommendations based on what the country or any academic institution, they need to move forward to enhance the system so that migrants could benefit from the health services and their health can be monitored. What we did, we just did not limit ourselves in publishing the report. To publish the report, it took time. But based on the preliminary findings, we suggested the Ministry of Health to develop a technical working group, inviting all key stakeholders as identified during the mapping process. Accordingly, the Ministry of Health, in order to develop this migration health management information system, they formed the technical working group. They did the consultation. We also supported from one of our projects. And before I left, we organized a series of consultation meetings, even to design the MHMIS, which was envisioned in both the plan and the policy, so that it can integrate within existing health information management or the information management system, so that all the relevant stakeholders can access and they can keep the record of, so that the system itself can have the comprehensive and systematic record of all data. And we also conducted the feasibility assessment and a separate stakeholder consultation to develop the system, especially focusing on the interoperability and necessary facilitation of integration within the existing government information management system, because it was one of the issue or the challenge that the stakeholder mentioned during the scoping review. So this is how we try to incorporate all the recommendation or the issues and challenges identified during the process to have a good system in place which in future can support the policy and programming with evidences.
Thank you very much, Dr. Farah and Dr. KC, and thank you all for listening. Please feel free to share feedback with us. See you in the next podcast.